Instead of just memorizing textbook biology today, we're going to do something truly fascinating in this explainer. We are going to reverse engineer the human heart. We're going to look at it exactly the way an engineer looks at a highly sophisticated, beautifully designed machine. Because by the end of this, you won't just know what the heart does, you're going to understand exactly how it works, and more importantly, how clinicians actually figure out when that machinery is failing. Okay, let's dive right into this. At its absolute core, the heart isn't just this single magical muscle. It's really a dual pump engine, perfectly synchronized with its very own built-in electrical grid. That's honestly all it is, an incredibly reliable system of plumbing and wiring. And when doctors are diagnosing a patient, they're essentially acting as mechanics. They're checking the pipes, listening to the valves, and reading the electrical output just to find out where the problem is.
So, here's our roadmap for today. We're going to trace the plumbing system, check out the electrical wiring, and learn how to literally listen to the engine. Then, we'll see what happens when the system fails, check the JVP water tank, and finally decode the ECG printout.
All right, starting off with section 1, the heart's plumbing system. Let's map out those pipes. So between the chambers of the heart, we've got these valves, right? The tricuspid, pulmonary, mitral, and aortic valves. As blood travels from the body to the lungs and then back out again, I want you to think of these exactly like one-way doors. Their entire job is to make sure blood only flows from high pressure to low pressure and absolutely never misfires backward. When the ventricle squeezes, that entry door literally has to slam shut and the exit door has to swing wide open. Now, the absolutely crucial point here is understanding the pressure differences between the two sides of this pump. The right heart, well, it's a super low pressure system because it only needs to gently pump blood to the lungs, which are, sitting right next door. The left heart, on the other hand, is a high pressure beast. It needs immense power to push blood all the way to your brain, down to your toes, and everywhere in between. So remember this golden rule: right equals 25, left equals 120. The right ventricle peaks at around 25 millimeters of mercury, while that left ventricle is flexing with a whopping 120 millimeters of mercury. Moving right along to section 2, the electrical wiring grid, sparking the engine. So we have the plumbing, sure, but a pump isn't going to squeeze without a spark. The heart has this built-in battery system that tells the chambers exactly when to contract, and it fires in a very specific rhythm. Walk through the sequence with me, it's pretty cool. Start, pause, go, split, pump. It begins at the SA node. Think start always. That's your pacemaker. The signal then hits the AV node, where there is this absolutely crucial 0.1 second delay. Why? Well, because you have to give the ventricles time to actually fill with blood. So remember, AV equals avoid rushing. From there, the signal goes down the bundle of His, splits into the bundle branches, and finally reaches the Purkinje fibers to trigger that big synchronized pump. Start, pause, go, split, pump. But what actually controls the speed of that pacemaker? That would be your body's autonomic nervous system, acting essentially as a gas pedal and a brake. The sympathetic system, that's your gas pedal. It uses adrenaline to ramp up heart rate and the force of the contraction, perfect for when you're running from a bear, right? The parasympathetic system, driven by the vagus nerve, is your brake. It slows the SA and AV nodes right down, which is perfect for resting after a big meal.
Okay, on to section 3, listening to the engine, sounds and murmurs.
Bringing this directly to the patient's bedside, clinicians literally act as mechanics. They diagnose the health of the heart by simply listening to its valves opening and closing. When you hear a heartbeat, that classic lub-dub, you are quite literally hearing doors slamming shut. The lub is S1, the entry doors, the mitral and tricuspid valves, slamming shut as the heart starts to squeeze. The dub is S2, the exit doors, the aortic and pulmonary valves, closing when the squeeze is completely done. But sometimes you hear extra sounds. An S3 sounds kind of like pathological sloshing, right? It means fluid is rushing into a failing, overloaded heart. And an S4, that indicates a really stiff, non-compliant ventricle, basically a failing pump struggling to receive fluid. Now, by knowing exactly where to place a stethoscope on the chest, clinicians can listen to those specific doors. But what happens when the flow isn't smooth? That's when we hear a murmur. And honestly, a murmur is just chaotic, turbulent fluid flow. There are really only two reasons this happens. Either the valve is way too narrow, which we call stenosis, meaning the blood is really struggling to get through, or the valve is leaking and blood is flowing backward, which we call regurgitation. By mapping out whether that turbulent sound happens during the squeeze or during the filling, we can pinpoint exactly which valve is failing. It's like a giant diagnostic puzzle.
Which leads us perfectly into Section 4, when the system fails. Dyspnea and congestion. If the left ventricle pump starts to fail, it sets off this devastating domino effect. And this brings up a really critical diagnostic question. Why do some patients feel perfectly fine sitting upright in a chair, but the very second they lie flat in bed, they suddenly can't catch their breath?
The answer is literally just gravity and mechanics. This condition is called orthopnea. See, when a patient lies flat, the gravity that was keeping blood pooled in their legs and abdomen is suddenly gone. All that blood rushes straight back to the heart. Now, a healthy heart, it just pumps a bit harder to handle the extra volume. But a weak, failing left ventricle simply cannot handle that sudden extra fluid load. Think of your lungs like a dry, airy sponge. With nowhere else for the blood to go, it immediately backs up into the lungs, turning that dry sponge into a heavy, wet, congested one. To remember this, just think ortho equals on the bed, breathless. The simple fix? The patient sits up, gravity pulls the fluid back down, and they can breathe again.
All right, Section 5, the JVP water tank. Looking at the neck.
So we've talked about the left side failing, but how do we actually check the right side of the heart without using, invasive machines? We simply look at the patient's neck to measure the jugular venous pressure, or JVP. I want you to picture the right atrium as a small water tank, and the jugular vein in the neck as a completely transparent pipe attached directly to the top of that tank. Because there are literally no valves blocking the way between the neck vein and the heart, whatever pressure changes happen in that right atrial water tank are instantly visible as pulses up in that transparent pipe in the neck. Now, medical students notoriously dread trying to memorize the JVP waveform, but it's really just a simple, highly logical story of filling and emptying. Let's break down the waves. The A wave is when the atrium contracts, A for atrium. The C wave is this little spike when the tricuspid valve closes and bulges backward, C for closure. Then the X descent happens as the atrium expands and relaxes. The V wave slowly builds up as venous filling happens, V for venous. And finally, the Y descent drops sharply as the valve opens and the blood empties into the ventricle below, asking why did the blood go down? It's really that simple. Contract, bulge, relax, fill, empty. A raised JVP simply means the right heart is failing and fluid is backing up the pipe.
Finally, Section 6, decoding the ECG, reading the printout.
To decode an ECG, we basically take that electrical wiring grid we discussed earlier and we literally print it out on paper. Every single scribble on this printout maps to actual physiology. Take the first small bump, that's the P wave. That's the SA node firing, causing the atria to contract. Think P for push blood. Then there's a flat line called the PR interval. That is that crucial 0.1 second delay at the AV node. Think PR equals pause required. Next up is the big one, the QRS complex. This massive electrical spike is the ventricles contracting. Think QRS equals quick spike. Finally, the T wave is just the heart resetting and repolarizing for the next beat. Think T equals time to relax. Push, pause, spike, relax. When you see a 12-lead ECG, you are literally just looking at this exact same sequence from 12 different camera angles around the chest. It's brilliant. So, as we wrap up this explainer, I want to leave you with this provocative thought. If we view the heart strictly as an engine, how does decoding its mechanical sounds, its fluid pressures, and its electrical printouts change the way we repair it? We've stripped away all the mystery today and seen the plumbing and the wiring for what they truly are. The next time you feel your pulse or hear a heartbeat, remember the incredibly precise, synchronized machine working constantly inside you. Thank you so much for joining me today. Keep learning and keep looking at the machinery behind the magic.